Okay, ladies and gentlemen, I think we'll start first because this is really meant to be very informal and casual. I think, we just want to showcase what cardiovascular care resilience looks like in terms of providing seamless care to patients in Asia. And I think, one of the things that we like to start off by saying is it's pretty obvious that cardiovascular disease is the leading cause of death in Asia. And in fact, public and policy awareness of CVD is low. Many believe that CVD only affects the elderly, high-income populations, or those living in cities. But unfortunately, this is not the case anymore. And in fact, we are seeing in rural China and India higher CVD caseloads. In Southeast Asia, some countries such as Malaysia and Vietnam might even see younger patients with heart failure who present with heart failure 10 years earlier than in the West. And at the same time, we see that universal health coverage for NCDs, including CVD, has stagnated in comparison with infectious diseases, according to a UN report last year. So, launched in June 2023, the APAC CVD Alliance intends to address some of these gaps with the mission of elevating public and policy awareness of cardiovascular disease across 9 focus countries in the region. And we adopt a patient-centered approach that recognizes patients usually have multiple comorbidities, such as diabetes and kidney disease. And we want to create a genuinely multi-sectoral coalition of patients, healthcare professionals, academia, nonprofits, think tanks, media, and corporate partners. And in addition to our regional and global partners, we also have partners in Australia, Korea, Malaysia, and Thailand, and will continue to build outreach further. The flagship Alliance report that was released on 28th of February examined CVD policies across 9 focus countries in Asia, and that's Australia, Japan, Korea, China, Malaysia, Thailand, India, Indonesia, and Vietnam, to examine the patient care continuum of prevention, early detection, treatment, and rehabilitation. And I think while there are differences based on income, as we can see, it was quite clear that every country needs a cohesive CVD national strategy that incorporates coordination within central and subnational governments, within primary to tertiary care as well. And this strategy, this cohesive national strategy, needs to achieve 3 outcomes. The first is really to reduce premature deaths. The second, to reduce hospitalizations and rehospitalizations. And the third, to curb the rise in new CVD patients. And the Alliance report also identifies priorities, including emergency care, early detection and diagnostics, cardiac rehabilitation, healthy diets, physical activity, as well as key system enablers such as financing, data, evaluation, and workforce development. And I'm happy to announce that the full report is now available on our APAC CVD Alliance website. So how then can we tackle these gaps in our health system to ensure a continuity of care for patients to avoid premature deaths, hospitalizations, and rehospitalizations? How can providers, payers, and governments do the same to ensure quality outcomes? And so without further ado, we are happy to welcome patients, cardiologists, cardiac pharmacists, and payers from Australia, Malaysia, Singapore, and Thailand. And this lunch dialogue will be moderated by Dr. Krishna Reddy, CEO of Access Health. So may I invite Dr. Reddy and our panelists on stage, who include Dr. Chayut Kunanuson, Senior Advisor of the National Health Security Office in Thailand, Dr. Christian Verdicchio, Chief Executive Officer of Heart Support Australia, which is an Alliance patient partner, Dr. Doreen Tan, Associate Professor at the National University of Singapore and Cardiac Specialist Pharmacist at the National University Heart Centre, as well as Dr. Raja Sharif, Head of the Heart Failure Service at the University Technology Mara and Alliance Knowledge Partner. So Dr. Reddy, over to you.
Yeah, thanks, Tim. And I think people are still trying to come inside. We deliberately removed the tables outside so that they should come inside. There might be surprise as to why this session is inserted in the conclave on health system resilience. Because in the discourse of health system resilience, a lot of leadership and a lot of stakeholders tend to forget that the healthcare needs of a dominant group which has taken lead across the countries, low-income, middle-income countries, that being cardiovascular disease in particular and the non-communicable diseases in general. So this session was taken from putting it as an example in terms of when we talk of resilience, and if you take a specific healthcare need of population, what is the dominant healthcare need of the population today in terms of the healthcare services is the cardiovascular diseases. Then most of the cardiovascular diseases, they present in a time-sensitive emergencies. That means you need to attend within that first golden 1 hour. And also we don't realize that the close interplay between the infectious diseases and the cardiovascular diseases. The major trigger for most of the acute major cardiovascular events, whether it's an acute MI or a stroke, is the infections. It may be a minor infection, but that triggers inflammation, that triggers the prothrombotic nature. So this interplay between the infections and the presentation of cardiovascular disease. So this is one relationship because our focus is on how to ensure the essential healthcare services during public health emergencies. So there is the interplay of the infections and the epidemics on the cardiovascular diseases, and also on the need to maintain and ensure continuity of supply, especially for the emergency care for some of these cardiovascular diseases. And third, of course, is in terms of the policy attention on this disease burden. Recently, there was a committee by the member nations of the Southeast Asia Regional Office, the WHO. Fortunately, there is a political commitment for the cardiovascular disease control as a part of overall health system strengthening. But when you look at the recommendations on the member nations, obviously the priority is to promotion of health, the prevention of cardiovascular disease. I mean, so the dominant priority in the articulated document was on promotion and the prevention. I think nobody has any dispute on those two aspects of priority for the member nations. But what is also not given importance is the millions of people with existing cardiovascular disease and their healthcare needs, whether there is enough supply of healthcare services to meet the existing disease needs, whether it is chronic disease management of heart failure or a management of acute MI or a management of acute stroke or a limb ischemia. So the document does not emphasize on balancing between the promotive needs and the preventive needs, but also the curative, the rehabilitative, and the palliative needs. So it would have been better for the document, for the member nations to have a much more comprehensive approach to this cardiovascular disease control than what is actually mentioned in the policy document. So this is in the context of that. I mean, this alliance of different stakeholders, both the policy as well as the non-policy stakeholders, was established and also fits into why, as a part of movement towards stronger and resilient systems, this aspect has to be addressed even by the low and middle income countries, because NCDs account for almost 60% of the deaths and 75% of premature deaths. But still, the focus continues to be out of NCD control. So based on this background, I think the panel, because I wanted to set why this topic was selected as a part of this session, I mean this conclave on resilience. We have a fortunate to have a good representation. One, the patient support group from Australia, Christian heads that group, in addition to heading rehabilitation programs in Australia. And we have on the provider side, Dr. Raja from Malaysia, cardiologist himself, and develops a lot of long-term continuity of care models. So on the provider side, and also we have Doreen from a pharmacy specialist. Unfortunately, we don't leverage the power of pharmacists in the health system for continuity of care. So we will get the perspectives from the provider perspectives, from the patient support group perspectives, and also more importantly, we have Dr. Chayos from National Health Security Office of Thailand, which is the largest the payer system from a public health insurance perspective. So what would be the payer's perspective in terms of the cardiovascular disease in general, and more specifically in the context of the recent pandemic experience, as to how does, as a payer, evolve into that. So with this context for this session, and given the short time, I would quickly start the discussion. Over to you, Christian. I mean, from your perspective, if you look from the patient angle, what their expectations in terms of the system level reforms for ensuring that continuity of care, especially during a public health emergencies. Of course, normal times as well, in terms of what are their expectations. While most of the systems focus only on the curative care, their expectation or health-seeking behavior in terms of rehabilitation care and the palliative care, so the whole life cycle of the cardiovascular disease. Please, over to you.
Cool. Thank you for having me here. And it's a privilege to be a partner also of the Asia Pacific Cardiovascular Disease Alliance. I think some very important things. And I say this to be, quite blunt, and even with our discussions and our advocacy back in Australia, there's still this reluctance to really act on cardiovascular disease. For us in Australia, it's the biggest killer. Number one in men, number two in females. It represents 25% of all deaths in Australia. The biggest impact on the healthcare system in terms of money, in terms of budgetary. However, we don't act on it appropriately. We're very slow. And when we think about how we typically treat cardiovascular disease, and I say this from Australia, but my subject expertise is in exercise cardiology and cardiac rehabilitation. I'm still somewhat of a clinician researcher. But the reality is that it's always focused on the acute care treatment, and then somebody else will deal with the long-term care. So if we bring it back to perspective, primary prevention of cardiovascular disease has been, let's be honest, crap. Fair? Hasn't worked. Right. It doesn't work. We're still here talking about cardiovascular disease. The prevalence continues to increase globally. no amount of money from the World Heart Federations in Australia, in England, wherever they are, in terms of primary prevention, awareness campaigns and awareness programs, have changed that message. Smoking has probably been the best effective primary health campaign in the last 20 or 30 years. And now vaping, our health minister's been very quick to crack down on that, in Australia, again, leading, the world around vaping, but primary prevention has not worked. We then have people who present to hospital on a range of conditions, and then when we think about, say, the rehabilitation afterwards to try and help these people transition to be back into work quicker, the quicker they're back into work, the more productive there is, the better it is for the economy, less reliance on social care and all these other type of things. Typically, only 30% of patients in Australia actually referred to cardiac rehabilitation, and then 30% of them take it up. So 9% of the Australian population take up some type of rehabilitation after they've had a cardiac event. That's not even counting the fact that AF patients are excluded from cardiac rehabilitation. My expertise is in AF. We did all the risk factor management studies in Adelaide. We changed the game, how it's treated. And purely because, even though we know exercise and weight loss can reverse AF, and cardiac rehab is perfect for it, there's so many of those AF patients that they can't do it. So they've just excluded them and just put them to the side. And so really the focus is still on acute coronary syndrome patients, so stents and bypasses. And then when we think about after they do their cardiac rehabilitation, which again on average is around 8 to 10 sessions, if that, across 4 to 5 or 6 weeks, patients are just generally pushed back to their primary care physician for some type of follow-up. Cardiologists don't want to see the patients until probably every 12 months. And so patients are really left in this limbo to what do I do? Primary care physicians are short at the moment. It's hard to get an appointment. Probably some of the quality of care isn't there as well. And so we see, in 12 to 18 months, 40% of patients with acute coronary syndrome re-hospitalised again in Australia. And if we think about 40% of hospitalisations, we know the data, around 40% of them are actually avoidable, purely because the patient has felt that they could stop their statin therapy because they felt better, self-medicate and stop their beta blockade therapy. They've ended up back into hospital for a worsening of their conditions. Whether they haven't really attended to their risk factors appropriately, whether they actually weren't appropriately medicated in the first place, all these range of things. And so, secondary prevention is probably key because, when we think about there's an opportunity that patients are most likely scared. They've got cardiovascular disease. They don't want to have another event. They don't want to have another stent or a bypass or an ablation. And peer support, for what we do in Heart Support Australia, peer support is starting to gain a lot of traction internationally in chronic disease care because it's people with lived experiences helping people who have a newly diagnosed condition and trying to come to terms. It's more cost effective. We're not paying for nurses and allied health physicians or cardiologists to be a part of it. It's people sharing their experiences, reinforcing some key education concepts because that's really important. Patients are always going on Google these days. They're on the phone for hours, probably reading the wrong things, reading the things that they want to read, ignoring the ones that they don't want to. And so getting together, on a monthly basis, talking about almost like the Alcoholics Anonymous concept, right? Talking about ideas, talking about what they're experiencing. Is it right? Is it wrong? Is it normal? Should I go back to my GP or my cardiologist? Should I not? It can help, what we find, improve people's quality of life because they feel comfortable. They're not the only one. Mental health aspects improve around anxiety and depression, leaving cardiovascular disease. So that's a real important win. And we tend to see that there's perhaps a less reliance to go back to primary care physicians or cardiologists for unnecessary appointments when not needed. Because, if you're talking in a room of, say, 10 or 20 people and you say, I've been having this lately, and another 4 or 5 say, well, hang on, we had the exact same procedure as you, that's quite normal, you won't make that phone call. But if 4 or 5 around the room saying, actually, that's not normal, you should go get checked out, then you can build up that courage and make the appointment knowing that you're not annoying them. And so peer support really can offer government's probably, I feel, a cost-effective way to help people in the secondary prevention stream try and stay away from hospital, get back into work quicker, contributing back to the economy better, and trying to be less reliant in terms of longer term type of other avenues, because the realities are, as much as we talk about it, we just can't fund exercise or risk factor clinics or these type, all the data shows it works. It's just not going to happen. You know, everyone wants money. And so if there's a cost-effective model, probably would be to use patients who want to give back and want to help, a way to actually do that in a kind of defined manner.
Yeah, thanks, Christian. I think it fits into yesterday's discussion as well in terms of the community empowerment and the community engagement, both through health literacy as well as through self-help groups. I think, yeah, there is a lot more to invest into that, both for primary prevention as well as for secondary prevention. In fact, in the last month, we were in Bangkok visiting the hospital there. They had an excellent volunteer patient groups. And as a part of their in-hospital orientation, there is interaction with the patient support group before surgery or before intervention. And then when they come for follow-up as well. I mean, it was a very interesting system of having the patient support group.
We actually do that as well. So we coordinate monthly groups across the country, and then we train up cardiac consumers or, you know, patients who want to give back. And so we'll train them up, and then we'll enter into an agreement with the hospital that they want to go to and provide what we call bedside support. And we find it's very beneficial. The cardiologists and the cardiac wards love it. And we find that getting somebody who perhaps is really down and out, shocked that they've got, you know, they've just had a heart attack or something, about to have a bypass. They've had a bypass and they're trying to come to terms with their scar because, you know, so having somebody who's been through that can be really beneficial to their long-term outcomes.
Now going to the other side in terms of the provider systems. I mean, so much innovations are happening and so much evidence-based guidelines are there. But when we look at the compliance with the drugs, whether it's hypertension, whether it's diabetes, whether it's heart failure, it's dismal. In fact, in the US, the evidence-based 3 drugs for the heart failure, only 17% of heart failure patients were actually consumed those drugs. I mean, that's the dismal thing. So given this, I mean, innovations are happening, but if they're not translating into actual compliance from the patient perspective, one, the patient support group should actually help in this thing. But more importantly, the allied team, it's a multidisciplinary approach rather than just a cardiologist looking at the patient. There is a great underutilization of the pharmacy as a key part of the member, the multidisciplinary team member, in ensuring this continuity of care, not only in the hospital, but because most of the compliance is out of hospital. I mean, that's where, and the most common interaction is with the pharmacies in terms of the refills and other things. So given these things, I mean, since the Singapore, a lot of innovations are happening in models of care in terms of the continuity of care and how to optimize care. Give you a perspective as a pharmacist, cardiology pharmacist, as well as who is working on some models of care as well. Doreen.
Thank you. I think, thank you everyone for having us here. And I hope that if you're feeling a bit sleepy from lunch, please go ahead and stand up and stretch around or think about questions to ask us later on. Yeah, so I think my main comment about how the whole system should be changed is mainly to tackle it at 2 angles of the whole cardiovascular disease spectrum. The more established one that we are familiar with is probably the secondary prevention group. And an example of how we've done that in Singapore is to build a digital health-based program called the AMI Hope. And the AMI Hope actually uses 2 key things in order to deliver care to the patients. One, using a platform where we deliver information to patients. And then the other, having a pharmacist trained in person-centered care their kind of communication skills in order to keep patients engaged in their care. Now, I think the more important question is ask, why are patients not adhering to medications and to health advice? I think there are many, many reasons for that. Firstly, we have all grown up in a system where we tell patients what to do, right? And hands up those people who have patients in clinic who nod at you, yes, 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 and then they leave the clinic and they don't do a thing that you tell them to do, right? So maybe a couple of things that we need to think about. One is perhaps lack of knowledge. And to address the lack of knowledge, that's what we're using the digital health platform to do. And we have programmed a series of information for the patients so that we send them out at regular intervals, thinking about how our experience was with patients, what we think they need to know right after a heart attack, and follow on. The other angle I think is important is how we speak with patients. Right? So I think I tend to also let's back in how we are very task-oriented. And as a pharmacist, if you tell me, okay, this patient has a myocardial infarction, what I'll be thinking is, all right, this guy must have 2 antiplatelets, they must have statin, they must have blah, blah, blah. The EF is poor, and we've got to add ACE inhibitor and beta blocker and all that stuff. So we get very task-oriented. And we forget to focus on the patient. So I think the far more important thing is to train our healthcare professionals to refocus their conversations around the patient. First, getting where the patient's values and beliefs are first before we start to impose what we think is important for them to get to goals. For example, the patient that comes to clinic who has difficulty trying to take their medicines in the morning, how many of us are guilty of nagging at a patient? Like, oh, you must take your meds, you're going to die, if not, you're going to get a heart attack and blah, blah, blah. So perhaps the next conversation we should be having with the patient, and a more suitable one, would be, well, what time do you wake up in the morning? What were you doing in the morning that led you to forget to take your medicines? And I think going down to the conversations of what the root cause is fairly important. I think this is even bigger a problem in primary care, right? Because the patients have not had a heart disease. Someone who had a heart attack would be, oh my gosh, I nearly died, right? They're more likely to be adherent. And yet, from our national data, we know that up to 30% of the time, after 3 years from their heart attack, 30% of these patients have stopped following up their primary care physicians. That is really troubling. So in the primary care, and as you've pointed out very rightfully, Dr. Krishna, the people who are non-adherent to statins, in Singapore, we know that the non-adherence rate is a whopping 60%. Like, it's more than half of the patients who do not take the statins as prescribed. So hands up the people who have heard about stories when you hang out with friends that, oh, statins will fry your kidneys or they damage your liver. And this is sort of things that our patients deal with. So what are we doing about this misinformation of our patients? So herein comes the next study that we're rolling out soon, and that's the app-based kind of a coaching study where we are going to try to coach non-adherent statin patients back to health. The more important thing is now utilizing AI, for example, to kind of curate according to a patient's digital phenotype. Perhaps their worries are more of concerns. And so could we use AI to tailor the kind of information to give to these patients, as opposed to someone who just doesn't have the information? Maybe we could use AI to tailor information according to give our patient. So instead of giving our patients the boring A to Z that we are so trained to do, perhaps we can tailor information for our patients so that it hits them where it motivates them the most. So I think by and large, using the systems and available tools are important. I would say maybe the biggest problems that we face locally is perhaps, as I think Christian has pointed out, the willingness to pay. In Singapore, if you tell your patients that you need to pay even $2, they will be saying, why isn't the government paying for my healthcare? That's something that I should be given. That's what I'm entitled to get. So I would say that the biggest challenge that we've had so far rolling out the AMI Hope program is getting the patient to co-pay for that particular program. And when you tell them upfront that, oh, you know, you have to put in $300 just for 6 months, they're like, what, $300? That's one of the biggest problems why we have not been able to enroll patients into that program. So I think to roll out person-centered care, in theory, seems easy, but in practical terms, financing is very challenging.
Thanks, Doreen. I think they were the right perspectives in terms of, because that concept of just giving the prescription and thinking that the patient will follow, That is changing, and in fact, more and more emphasis in terms of the multidisciplinary approach in terms of the continuity of care. Because, some of these things are not coming into the system level planning and the policy level planning. I mean, one of the attempt of the Alliance is to bring this into the consciousness of why it is critical to invest into some of these models of care. Thanks again, and I move on to Dr. Raja. As a cardiologist and driving, I think, some of the heart failure programs. Fortunately, I do run the heart failure program, so I can resonate with what you are trying to do, because that is one of the key requirement. As the more and more people are surviving the acute heart attacks, they are left with the damaged hearts, which ultimately progressing to the heart failure, and they constitute now more than 50% of hospitalizations across most of the systems. And given this thing, and given the fact that their longevity after diagnosis before invent of the drugs was 3.5 years. But with the advent of innovations and generation of evidence of 3 drugs or 4 drugs and some of the devices, now the lifespan is extended to 17.5 years. But unfortunately, as I mentioned, only 17% of the patients with heart failure are actually on evidence-based therapies. So this is where that multidisciplinary approach to ensuring that they get benefit from the evidence therapy, and without investing too much into infrastructure. It is purely the people, the processes, the communications, and engaging the patients when they go out of the hospitals, out of the clinics, even into their homes, how we actually continue that care. Over to you. I mean, how you're able to achieve that.
Yeah, so again, thank you very much for having me and inviting me to join the Asia Pacific Cardiovascular Disease Alliance. So just a bit of background, I run a heart failure service. We're not the oldest, but we have had experience trying to implement a lot of new strategies as per what the European Society of Cardiology would recommend, or what the American guidelines would recommend, etc. I would say that an MDT approach, or a multidisciplinary team approach, is currently gold standard when it comes to heart failure. But that's all in paper. Now, when you're doing it, when you're on the shop floor, it's a very different story. Again, based on experience, initiating an MDT clinic or an MDT-based clinic is easy. The components are there. You've got your physiotherapist, you've got your occupational therapist, you've got your pharmacist, etc. The problem really lies in gelling all of them together. And that's sort of still a struggle for my service, at least at this point in time. Just for example, cardiac rehab. I think Christian pointed out a very important point, actually, and it actually resonates with me as well, even though we're from different countries. There's so much reluctance still with referring patients over for cardiac rehabilitation. Fair enough, I work with the end of the spectrum of heart disease, heart failure, so they are fairly fragile, but fragile doesn't mean futile. I think that's a very important point that I want to sort of get across. These patients actually do have benefit, or at least cardiac rehab can confer a degree of benefit, if not more, when it comes to improving heart failure with cardiac rehab. But still, we're getting a lot of clinician inertia with regards to referring patients over. In fact, we were discussing over dinner a very funny story. I was asked to give a cardiac clearance for a patient to go ahead with cardiac rehab, and it was quite silly because I did the referral in the first place, so obviously I've cleared the patient to a certain extent. But that's just the degree of fear or anxiety that other clinicians have as well when it comes to engaging with cardiac rehabilitation. So that's just one example. The other would be dietitians. So in my setting, dietitians, can you imagine trying to overhaul a complete inpatient menu that is fit for heart failure in a hospital, let alone a whole healthcare system? And as rightly pointed out, 50% of admissions or readmissions is heart failure admissions. So you really need to tailor the menu accordingly. And that's a difficult task to undertake. And dietitians then get relegated to sort of much more minor roles, unfortunately, of advising patients just in clinic, just because you can't do the bigger stuff. So that's just some of the examples, really. I think what was pointed out earlier as well about underutilization of pharmacists is a really big issue, when really the solution when it comes to heart failure management is decentralizing prescription, for example. But when you talk about decentralizing prescription or privileges over to pharmacists, it becomes a whole big issue, and there's egos in play, there's politics involved, etc. We don't want to get into that. But we've seen successes in other countries like the UK, for example, where they've actually allowed, to a certain extent, certain pharmacists to prescribe certain medications, and it has helped a lot in the community setting. So that's things that, can help, definitely, but have not yet been implemented, at least in my setting. Now, with regards to MDT, having said all this fairly negative things, I still think embarking on an MDT approach, an MDT clinic, is still worthwhile. Because, for example, my setting, the hospitalization rates for Malaysia in the first 1 month for heart failure is about 10%, maybe up to 15% in the first 1 month. It goes up to 50% over time. But we managed to actually reduce it down to like 2 to 5% in the last 1 year, which was quite good, despite all those barriers. Now, the one thing I would remind people is that's not all there is really with regards to MDT approaches, because you're still missing out a lot of gaps when it comes to heart failure. So the one area that we've realized we've missed out on are patients who just don't make it to their first appointment. So the really sick ones, but obviously hospital can't keep them in because the average inpatient stay in Malaysia is 5 to 7 days. So after 7 days, they do get shipped out regardless of their clinical status. And then they don't make it to their clinic appointment because they're probably dead at home. So what we've done is we've taken that on board and we sort of extended our service. So we've introduced this thing called Ward from Home, which really is virtual clinic. As you guys know, virtual clinics were all the hoo-ha during COVID and all that. But we've taken a bit of a spin to it. We've actually used it just for those subset of patients who we felt were at risk of deteriorating, and sort of contacting them virtually in the first sort of 1 week or so, just to touch base, see how they are. Nothing too fancy, not changing any prescriptions per se, but really just, again, to touch base, find out if they're okay, and if they're not, whether these kind of patients would warrant an earlier follow-up or would warrant a readmission as soon as possible to avoid those kind of situations. So I guess that's where the MDT approach comes in.
Yeah, I think, this is exactly the three perspectives are what I call the triangle of governance. At a system level, one is the people's perspective. I think that's what we heard about what we can do at a community and the people level as a part of this overall governance. The second perspective is the provider system, the innovations that are happening in the provider system, especially on the process innovations. It is not just the innovations and technology, but the process innovations that are essential. And the example of cardiovascular disease, why it is illustrated here is the same principles are applicable to all the healthcare needs. Whether it is cancer, whether it's lung disease, whether it's kidney disease, the principles remain same. The third limb of the governance, and which is critical in terms of the system's approach to the disease control from the payer's perspective. I think that's where I would ask Dr. Chayos 2-3 aspects from the payer's perspective. One is, as a payer, like from the Thailand National Health Security Organization, one concern from a payer perspective is that since the cardiovascular disease is driving the health expenditure across the countries, and it is driving to a level where it is becoming unsustainable. As the people age, as the disease burden increases, as the diabetes prevalence increases. So most of the low and middle income countries are going through that. So that means there is a direct impact of the cardiovascular disease management on health financing and health expenditure. That's one. The second is the impact of cardiovascular disease on the economy of the country. Because most of the premature deaths that are happening in these countries, as I mentioned, almost 3/4 of those deaths are due to the cardiovascular diseases. That means most productive time period of these people, they're dying. So that has an economic impact in addition to the health expenditure impact. And thirdly, as most of the countries are moving towards the universal health coverage, which initially focused dominantly on hospital-based care, but now moving to include, especially because most of the non-communicable diseases require lifelong care, long-term care. It is not just episodic care. In the context that 80% of the expenditure happens out of the hospitals, or even the 90% of the expenditure. So given this dimensions of impact on the economy, impact on the health expenditure, and also need to cover the continuity of care. So your perspective from, as a payer, the largest, one of the leader in the universal health coverage from Thailand perspective. Over to you, Chais.
Thank you. Can you hear me? Thank you. Thank you very much. It's a big burden, Professor. That's true. It's a big burden for supporting cardiovascular disease services. I can tell you the magnitude of this. Annually, it costs Thailand about 10,000. No, what I call 10 billion Thai baht every year. So that's a lot for us. And among this, you are correct that many services are more effective out of hospitals. So we are trying to move from in-hospital into more community, and that good examples from Australia and good examples from Singapore and Malaysia. By the way, we fly from Australia to Singapore to Malaysia and then fly to Thailand. Right? So this is a good sequence. Next we fly to India. That's correct. We have, this is a big burden for every country. And I would say that in Thailand it's not an exception. And we try very much to move into another direction of not in a hospital, as I mentioned earlier, and try to move into what we call value-based care that engage more patients into the system. So let's have my PowerPoint, please. I can share with you what we have been doing and what we think. So in my presentation, which will take about 7-8 minutes, I share with you what we are thinking on doing this. Thank you, Professor. First thing on the framework of the success model from not only on this stage, but from other cases also. We need 2 elements to make success cases or success model. The first is resources. And in terms of resource, I would say there are financial resources, staff, equipment, logistics, and good data. These are 5 essential elements of resources. And on participation, this together, the participation must be from patients, provider, and payers together. And you see the representative of patients, he's not the patient, but he's represent a community group, Christian, right? And providers, and I represent the payers in Thailand. I will share with you the example from Thailand. The question that we are trying to, the challenge is to move from the current situation into the next situation that we have quality care along with quality and value-based care altogether. And there are 3 elements for us to put together in order to move effectively into quality and value-based care. The first thing, the first element is to make sure that service quality is standardized, and not only quality, but standardized quality. The second element is to make sure that there will be sufficient participation of, let's say, the 3 parties, the patients, providers, and payers. Now we are payers. We want to make sure that the weakest element, the weakest part of the 3 parties, which is the participation of patients, will be high enough. So that's the second element. And the third element is to make sure that we have sustainable resources and sustainable quality services. So this requires some other things that can be put together to make sure that they are in place. Sorry, I don't know where to point this. Okay. The first thing on the standardization of service quality, we have this system. We have the system to register cardiac centers in Thailand. There are about 80 qualified cardiac centers registered with us. And to register them, we looked into 8 perspectives of this on the screen. The first one is on the setting up and the equipment. I don't want to go into detail of this. We have checklists of many things on the setting, the size, and list of equipments. The second aspect is to make sure that there is enough personnel, and this includes cardiovascular, includes CVD, cardiologists, and also we mentioned the pediatric cardiologist also, a nurse, ICU nurse, and perfusionist. We have the list of these personnel, and they are in the checklist. We have to make sure that they are, there is sufficient number and quality of this personnel. The third element, we look into the management, and this is important because we have to make sure that each and every cardiac center has what we call cardiac lab director. The director must do his or her job on putting together and make sure that everything is in place. And every time we want to communicate with the cardiac center, we do it through the cath lab director. The third element is on service quality, and we measure this through the compliance of the service system to the guidelines. The fifth one is on data management, and this is important as we all know that we have to make sure that proper data are collected and report in the way that it is helpful for the fine-tuning of services. In terms of quality assurance, we looked into total quality assurance and ISO. This is very helpful if the cardiac centers has applied and successfully approved by these quality assurance schemes. Now the remaining 2 items, the inspector opinions is an open-end recorded field, and the other remarks also is another open-end field. So we still have open-ended field for anything that we did not think of or anything that emerged later on in the system. So we looked into these 8 aspects, and we do registration to make sure that each cardiac center is qualified to this. And it is not only one application and stay on. We need to have self-assessment every year. We do this annual self-assessment for supervision and monitoring every year. I have to tell you that this might look good on the screen, that we have many good things like this. But it has been weakened during the COVID-19 pandemic. We did not have sufficient assessment, and many cardiac centers have been away from what they should be. So this year, we come back into more intensive inspection of these cardiac centers. So those are 2 elements that we have to make sure, registration and self-assessment. Now another thing is we do close monitoring of service qualities through the outcomes, and we looked into mortality rate, we looked into complication rates. In order to do this, you might recognize that we, in the NHSO, we have limited clinical data. So we request cardiac centers to fill in more clinical data. We call this 1 page. And we've got focus on CAG first, because this is the most common procedures for CVD care. We call it 1 page, but actually it's 2-3 pages. Anyway, it's 1 page. It's a nickname for this. The point is this: we request cardiac center to enter data into the system and we look into the data. Now, many of you might ask whether how to make sure that they put data in the system. We bind it to the claim. And there has been an announcement from NHSO that without proper filling up of this form, the claim will not be processed. And we do this through the computer system, that once they fill in the form, something that we call registration number of this CAG form will be generated by our computer system, and they can use that number along with the claim data for reimbursement of this. And this is an example of the dashboards that we use from data. There are 6 pages, and I bring to you only the first page. We have this demographic data of cases that went through the CAGs. Tell us some of the categories, whether they were diagnosed as chronic coronary syndrome, or STEMI or non-STEMI or other things. And also we collected data on significant findings from CAGs, and we have significant rates by groups of them. You might notice that there is almost exactly the same of the upper part and lower part. The upper part is the national numbers. That means the national or the regional numbers. On the right-hand side of the upper part is the mortality in box plots. So we have mortality rates of the region. Now the lower part is for a particular cardiac center. They can put in their H code, hospital code, and then they see what they are doing in comparison with the national or regional statistics. So in this example, you see that on the lower part, you have one mortality rate. That is, I don't know, it's 3% or 5% something. So the hospital, the cardiac center knows where their place is in terms of the region. So they can compare their mortality rate to the region, to their region, and compare the mortality rate to the nationwide mortality rates also. So we have 5 other pages of data from this, and that serves for close monitoring of the service of each cardiac center. Now the third one, this is in our plan. We want to move, as I mentioned earlier, to move from intervention-based claim system. Now when I said claim, this is in supplement to something I mentioned earlier on registration of cardiac center. To do registration of cardiac center, we make sure that cardiac center is qualified to provide services. Now, at intervention, at claim level, we also, I don't want to use the word regulate, but we use this as another tool to ensure quality, because when the claim comes in along with, as I mentioned, along with the number, and we process the claim, we still have opportunity to say yes or no to the claim. And for the no or for the pending ones, we request for more information. So that is the system to make sure that we provide, we allow reimbursement for cases that have been in at good quality. Now, that is still, from our perspective, is still not good enough, because we want to move from what we call intervention-based claim into more of the case-based claim. And this is to address the problem of having too high mortality after the intervention, after CAG or PCI, whatever. So we are applying the package of care, of supporting the package of care, that the claim can be provided for the whole year, not only for only intervention, only that specific intervention, but also allow for the whole year. Post-intervention services also. And that's we call package of care. It's possible because we follow the NCD, cancer care models. We have cancer care that is packaged already. Okay. And the challenge on this is on patients, providers, and data system. I don't want to go into detail of this. The second element of moving towards quality and value-based care is to make sure that the patients are empowered. I use the word empower because we want to not only educate them, but we want to hear from them also. And this is the critical elements of value-based care. We have to say that this is in very near future because we want to have patients review in the same way as when we ask for online delivery and or Grab or whatever, and we give 5 stars, 4 stars to the service. We have been testing this with the telemedicine, and it's doable. I use the word doable because it's doable for telemedicine because at the end of the telemed session, we ask patients to say good or bad or whatever. So we hope that for CAG and CVD services, we will be able to apply these experiences into this aspect also. And eventually we aim for choosing wisely, that is to empower patients so they know what to negotiate with the providers. Now the last element on policy advocacy, we plan, not really in place, no, is it over? No. we have, as I told you, the one page that we have data from one page and we do analysis of one page. Very soon we will have patient feedback and then we have cardiac center self-assessment. When we put these together, we believe that we can triangulate what is really happening in the field, in the service system. And we will use these findings for evidence-based advocacy for sustainable resources and sustainable quality services. Now, in conclusion, sorry to take a lot of time, but I want to share this. There are 3 things that will go together to make sure that sufficient resources are in place, and from that, we have to foster participation of 3 parties, as we know, the providers, patients, provider, and patients and provider and payers together. And that will build up good monitoring system altogether. And this will go together, and we believe that all of this will eventually bring us into quality and value-based care. Thank you.
Yeah, thank you, Dr. Chayos. I think that's a wonderful lesson to a lot of us in terms of how a payer system actually can drive the quality of care, because it's not just enough to have financial protection if you don't assure quality. So the accountability and the responsibility of a public health payer is also towards ensuring that the patients are getting safe and effective care. I think that's what I think the clear, practicable people can learn and adopt some of the systems which have been used in Thailand in terms of how to drive the value-based care. So because I think we are stepping into the next session, there is no intermission in between. We may not take any questions, but I think it was a rich discussion. Again, I wanted to summarize that this is the triangle of the governance where the patients, the providers, and the payers, the 3 together acting to deliver what is best possible and what is best financial protection that can be given. With this few closing remarks, I thank all of you for a wonderful discussion, and we hope to continue these dialogues as a part of the Alliance. And since there is a shared purpose, how these countries can achieve that control of the cardiovascular disease, and controlling cardiovascular disease and non-communicable disease contribute towards the resilience. So that's the linkage to the resilience for this session. Thank you all.